Good afternoon, everyone. I am Dr. Rahul Mandlik. Would like to welcome you all on behalf of Shalina Healthcare to this webinar. Today, uh, today's session is based on World Malaria Day. Like every year, World Malaria Day is observed on April 25th, and from recent World Malaria report, it has been reported that globally 247 million new cases of malaria are registered in 2021, out of which 95% of these cases they occur in Africa region alone. So to address these concerns, this year's World Malaria Day theme by WHO is Time to Deliver Zero Malaria, Invest, Innovate and Implement with special focus on last I, that is implement, and also focusing on reaching to the remote populations or marginalized populations by using the tactics or tools and strategies available currently in the control, prevention, and management of malaria. In this line, today we have a brilliant panel that comprises of different healthcare professionals who are going to brainstorm on the changing epidemiology of malaria elimination, new strategies for new challenges. So before to that, very briefly about us, Shalina Healthcare. Today, we are one of the largest pharmaceutical companies in Sub-Sahara Africa, and from last 40 years, our mission is to make available quality and affordable medicines across Sub-Sahara Africa. And we achieve this by manufacturing our products in WHO approved facilities. And we own a social responsibility. That's how we are partnering with several NGOs, with medical, pharmaceuticals, and nursing institutions. And we strongly believe in patient centric approaches and providing continuing educational opportunities for our healthcare professionals across the continent. Today's session is brought to you by Shalina Academy. This is an educational initiative by Shalina Healthcare. So, with this, let me initiate today's program by introducing to you with our eminent panel members, starting with Dr. Grema. Sir is Sir is a chief consultant family physician at Family Medicine Department, Aminu Kano Teaching Hospital, Kano, Nigeria, and sir is the first vice president of Nigerian Medical Association. And sir is leading some national assignments, like he is a member of technical working group at National Influenza Pandemic Control Program. He is the coordinator of National Influenza Sentinel Surveillance as well as NCC Laboratory at Kano. He is a member of National Project Implementation Committee of NHIS Enterprises as well as a member of Finance Strategy at NHIS Project Resource. Sir is a participation in the conduct. He's actually participated in the conduct of HIV/AIDS seroprevalence surveillance and provider of integrated confidential testing (PICT). Dr. Grema has published more than 50 publications, and Sir has supervised more than 30 dissertations, both covering malaria research as well. Welcome to you, sir.
Thank you very much.
Our next panel member is Dr. Chanda. Sir is a specialist physician uh, with a specialist physician in public health and NCDs at Department of Internal Medicine, Kitwe Teaching Hospital, Zambia. And Dr. Chanda is a mentor of drug susceptible as well as drug resistant tuberculosis. Sir is a founding fellow of Diabetes and Endocrinology Zambia chapter. So I think Dr. Chanda is facing some internet challenges, so we should have him very soon uh, on the call. Moving on to next panel member, Dr. Emmanuel. Sir is a chief. Sir is a chief pharmacist and clinical coordinator of pharmacy practice at University Hospital, Accra, Ghana, and he is a preceptor for pharmacy interns from the pharmacy training institutions. He is a former head of medical stores and equipment depot of Ghana Armed Forces. And Dr. Emmanuel is a secretary to Loans Committee at GCPCUL in Ghana, and he is also director tutor at EMEF Medicine Counter Assistant Training Center. And Dr. Emmanuel is actively involved in several continuing education programs, as well as he is an active member of several professional bodies. Welcome to you, sir.
Thank you.
And our next panel member is Dr. Teresa. Ma'am is a clinical officer. Ma'am is a clinical officer and working as a malaria program officer currently in Kisumu, Kenya. And under this role, ma'am is actively involved in providing CME as well as on the job training on malaria indicators, as well as she is facilitating distribution of long lasting insecticidal nets. She is ensuring timely reporting of malaria indicators at the KHIS, as well as conducting malaria data reviews and date quality audits. And she is ensuring constant supply of malaria commodity. And she also played a role. She also worked as clinical officer at International Center for AIDS Care Program, that is ICAP, from 2012 to 2015. And she also worked as a part-time lecturer at Tricent Medical College in Kisumu during 2021. Welcome to you, ma'am. So, audience flow of the today's program is like now I'm going to hand over to Dr. Grema, who is going to moderate this session. Dr. Grema will take us through very quickly the background of the topic and to set the right tone by using his presentation. Followed by that, we will have uh, introductory remarks from all panel members, and then they're going to be very engaging brainstorming on the topic between all panel members. And in the last part of the webinar, I will again come back on the live screen to take up questions on your behalf. So don't forget to post all your questions in the box provided on the right side of the live screen. So please stay tuned. Thank you so much. Over to you, Dr. Grema.
Thank you very much. May I now start sharing my slides for everyone to see? May I appreciate the opportunity given to us by Shalina Academy to make this wonderful presentation to enlighten and to exercise our conscience to the issue of malaria elimination. May I welcome my panel of discussants to this wonderful occasion. Also, I invite our participants that have joined us to be well groomed to the topic and then be part of what we're going to discuss. I'm just going to make a little introduction to the topics, which goes this way. We are here on behalf of Shalina Academy to celebrate the World Malaria Day 2023, which says that we should talk about disease without borders. Talking about disease without borders, the team emphasizes the need for global collaboration in the fight against malaria, including the need for cross-border strategies, well-documented good practice, which means good clinical practice, and a coordinated action at all levels, which is international, regional, national, and local level. And we've already seen that the majority of cases were reported in WHO African region, which constitute 90% of malaria prevalence. And there goes to say that the Southeast Asian region and the Eastern Mediterranean region constitute 7 and 2% of global malaria, respectively. Sub-Saharan Africa region has reported such a high endemicity that shares about 80% of total malaria burden. But there is a global decline in the elimination of malaria, which we expected in 2024. Whether we are on course or whether we're going to reach 2025 or 2030 is the question we're going to brainstorm on. Yeah, this is just to show us the global prevalence of malaria that I've just mentioned. What are the drivers of this decline and elimination? And it all go to be attributed to the scale up of combination of the following control strategies. That is the use of long-lasting insecticide-treated bed net or insecticide-treated net, indoor residual spraying, and intermittent preventive therapy for pregnant women and other special groups for prevention. Better diagnostic for case ascertainment and effective treatment using artemisinin-based combination therapies. What are these epidemiological challenges? The epidemiological challenges goes to be as the new challenges, especially in the new vectors that are now coming on board. That is the spread of one special Anopheles stephensi. It's a mosquito species that transmit both falciparum and fever-virus malaria. And it has a unique survival where it survives in the human well-reserved waters. So that means it lives within us in the community, especially in urban area. It was thought to be a vector in the Southeast and the Asian and then Arabian Peninsula, but now it has been found so rampant in the Horn of Africa. And then to be precise, it has come to Sub-Saharan Africa. Recently, it has been isolated in my country, Nigeria. So these are new challenges of epidemiology, especially when it goes to, and then the issue of virus that is form part of the migratory transmission of malaria. Then there are going to be epidemiological impact of insecticide-resistant, long-lasting insecticide net, and then residual indoor spray. And then the issue about insecticide-treated net is going to look at the net survivorship. The net survivorship here means that the longer time the net survive after issue, which goes to show how long it has damaged, what time it has been taken to get damaged by various factors, including even chewing by animals. And then the fabric integrity of the net itself is going to be an issue. And then the insecticide activity of the impregnated chemicals inside the net, that's bioefficiency. And then also the vector dynamic, whether those nets that we put into a house, the vectors have not changed their behavior, whether to rest in and outside where we sleep, or they bite in and outside where we sleep. Then the indoor residual spray also shows some resistance, and the timing of spray also is in question. And then the quality of spray, the person that is spraying, has it been spraying it adequately? And then at large, the cost effectiveness, because it shows that it has been a very high cost, especially in our rural areas. Then we look at the impact of the rapid diagnostic test, where we found recently the resistance by those parasites, especially those parasites that escape the RDT, that is especially Plasmodium vivax. And then there is this mutation of the histidine receptor protein 2 and 3 that has been seen to cause deletion and then reduce the sensitivity and specificity of the test. And then the complexity of our almighty drugs, the artemisinin combination therapy for both active treatment and for drugs for various chemoprophylaxis that we have. So it's an issue which we're going to brainstorm among ourselves with the panelists that I have on ground. Now, there is also an uninterrupted malaria importation into the malaria-free, where there's malaria-free and we are eliminating countries. And this got to do with a particular vector, the virus, has been found to be a vector that has been transported easily. Then the issue of global warming and then natural disasters, conflict all over the world, how it affects the elimination of malaria. Then coupled with the what we call human pandemic or human phenomena, where we are being afflicted with what we call when we have this COVID-19 pandemic, how it affects our malaria prevention, testing, and treatment services. Then there's an issue of changes in the clinical epidemiology as well, where we found an increase in the median age of hospital admission. Hitherto, we know the age group that had a higher number of hospital admission, that's 2 to 5 age group. Now we find out that the older children are being more admitted in the hospital. And we find out that there are some clinical changes where we find less anemia now as before. We are dealing with more of cerebral malaria. That means we are dealing with more severity of a complicated malaria. Then there is these emerging populations that are at risk. We find out that there are lots of adults that are harboring low density of malaria, and then school age children are also showing, and teenagers are also showing to harbor this parasite. So this low density parasitemia in this age group also brings about the increased transmissibility and goes to show the reduced elimination process that we're going to have. And there are some geographical risk areas, we call it hotspot, and then some silent sustainers. These geographical hotspots are a group of people, especially adults, where areas when they have a decline of malaria prevalence, you find a cluster of people, especially adult age group, that include household and also up to sub-regional level. So these group of people that harbor a small density parasite also have a challenge in the transmissibility of malaria. Also, some silent sustainers. There's a special group of people that are pregnant women, like adolescents, and then some special group of people also keep this parasite in them, and then issue of this vibex also from migration brings about reduced sustenance of malaria elimination. Then what are the strategies for these challenges? The World Health Organization recommend a shift to a receptor protein 2, which is found to be resistant in our RDT test, and then they seek to improve the diagnostic tool related to P-Vivex, because the RDT that we have now cannot detect this malaria parasite. And then there are several ongoing innovations in the malaria medicine for case management and chemoprophylaxis. One other challenge that we have for Shalina here is to look at their molecules and see how this thing will now bring innovation to avoid the resistance that we have. What WHO is recommending now is to have a triple therapy as against the double therapy that we have. So the combination of artemether lumefantrine should have another molecule added to it to make it more sustainable. The recent introduction of RTSS-AS01 malaria vaccine for prevention of severe falciparum malaria in children living in the region of moderate to high transmission has already been started, and we've seen good results in some countries. Ghana has started, and Nigeria just last week approved the use of this vaccine. So my final discussion will have to talk more on this and find out look at the challenges and profiles more solution to this. Then there are strategies called for collaboration. All what we're going to do require collaboration. And then we have to improve surveillance of what we achieve. And then the surveillance will be equitable and resilient for us to achieve our goal. Then, if you're going to look at the role of healthcare workers here, at various level of development, of various level of state and country, healthcare worker constitutes all cadre with barrier coordination and responsibilities across all levels of healthcare facility. So here our role is to ensure early diagnosis and treatment. The early diagnosis and treatment can happen at the malaria post, which is the basic unit where we tackle malaria. And this malaria post constitutes a minimal trained personnel. The minimal trained personnel should be able to take diagnostic tests with RDT and will be able to give appropriate ACT for cases. And this action should be taking place between 24 to 48 hours of appearance of malaria symptoms. And these people are the ones that are closer to the community. And then from there, we need people to have a channel of prompt referral from malaria post, which is the basic post, then to other referral centers up to the tertiary institution. And then healthcare workers should be involved in health education and counseling on prevention and control of malaria. Here it goes on to say it's just not to distribute ITN, it's just not to distribute prophylactics. People should be engaged based on their culture and tradition and have to have adequate information for them to use these strategic facilities that we have adequately. And then we have to participate in passive and active surveillance to identify the asymptomatic cases and to identify other vectors that are of importance. Then we have to use appropriate information technology, either for our in consumption and then for dissemination to the world. And then lastly, there has to be a monitoring and evaluation for us to look at what we do and take SWOT analysis for us to go ahead and then achieve the elimination of malaria, possibly, if possible, by year 2030. Actually, this form part of my introduction. Thank you for listening. And I think if I will be allowed, we just have to kickstart the discussion. And I don't know, among my members, I've not seen Dr. Chanda. Is he available? Dr. Teresa, can you unmute yourself? Dr. Teresa?
Yes.
Thank you very much, Dr. Teresa. Can you give us your own introductory remark? And by giving your introductory remark, can you just go ahead and give us a talk as we are seeing decline in the epidemiology, decline in the malaria prevalence in our region, and then how this affects the clinical epidemiology as we have emerging population at risk, and then there are changing parasites and vector population, and then their behavior change.
Okay, thank you so much. Oh, well, I want to start by saying that there's been a tremendous improvement in the management of malaria in the sub-Saharan Africa, and the implementations that have been put in place have been very, very vital. For example, in our region, you find that a lot of children under 5 are mostly affected, but again, malaria affects all populations, be it adults, children, expectant mothers. So the most at risk populations, we have the under 5s. And again, I want to say thank you for the introduction of the new vaccine. The expectant mothers too are at risk, but again, we have the IPTP that has put them on check. The interventions that have been put in place, for example, the IRS, there's level source management, there's LLIN use, that is the insecticide treated nets, have also been of great, we've achieved a great milestone. So as we proceed, I must acknowledge that there's a great improvement. There's a milestone that has been achieved, but still, yes, a lot has to be done because the parasite is still, it keeps mutating. There's a lot of mutation that has taken place, and again, there's a lot of resistance that has been realized. So still, there's much to be done. I'll start by giving that as my remark. but I'll continue giving my input as we proceed. Thank you.
Thank you very much. Dr. Chanda, are you back? Dr. Chanda? Thank you very much, Dr. Chanda. Though your video is not showing, can you hear me? Dr. Chanda, can you hear me? I think before you are set, can I go on to Dr. Emmanuel? Dr. Emmanuel.
Coming on the call.
Oh, Chanda, you are up.
Yes.
Thank you very much. You are welcome. Can you give your introductory remark? And also, if you can talk about this global warming that I've just started talking about, where our strategy has been affected by conflict, the global warming, and then if you can look at also leadership and management and then strategy toward eliminating malaria and other factors. Dr. Chanda, are you with me? Before Chanda set up, let me go to Emmanuel. Dr. Emmanuel.
Hello.
Yeah.
Yeah, give your opening remarks, introductory remark, and also talk about this clinical management of malaria.
Hello.
Including management. Yeah, I will come back to you, Chanda. Dr. Emmanuel.
Yes.
Clinical management of malaria.
Yeah, thank you very much.
After your introductory remark.
Yes, thank you very much, Dr. Grima, for the opportunity. I would say largely you have done a good job running it from A to Z, making it more simpler for all of us to add on. When it comes to clinical management, as you have already said, early detection of the malaria parasite is very important. In our parts, they declassify the condition as a simple ailment of common occurrence. So we should be able to detect it early at the primary facility using the rapid diagnostic testing. And at the hospital, they may have to go further to do the microscopy to establish the presence of the parasites. And with the way the condition is, the malaria disease affecting almost all the body system, affecting the central nervous system, with all kinds of nightmares, hallucinations, insomnias, affecting the circulatory system, the person complaining of dizziness, the digestive system unable to eat. All these drive the malaria to that level of high mortality. And if it is detected, then we should get a very good product in trying to treat the condition as early as possible. And in the past, we're using monotherapy. And even for the monotherapy, it takes about almost 30 years, 40 years to develop resistance to it. And so when the new program is rolled out using the ACTs, artemisinin-based combination therapies, where two derivatives, artemether and lumefantrine, for instance, are combined to be used. The advantage for the artemether is its ability to be absorbed rapidly, very fast, and it has a shorter duration of action though. But that rapid absorption allows for easy resolution of clinical symptoms and to put the patient at ease. Because it has a shorter duration of action, the addition of the lumefantrine, which rather have longer onset of action, but long half-life, allow the drugs to be in the body for about 4 to 10 days. And these do not, these tend to help reduce the recurrence rates of the malaria parasite. And this combination, these two combination in particular, the idea is to reduce the development of resistant strains. And if we can easily eliminate the parasite by treatment, reduce resistant strain, then there is hope for us. I saw the slide that you put, that the goal for malaria elimination is 2024, and one of the one of the
ambitious.
And one of the ways to match up that as of now is the historic introduction of the RTSS AS01 malaria vaccine, and which Ghana, Kenya malaria has piloted since 2019. And for Ghana, as of December 2022, about 1.4 million doses of the vaccines has been given. And out of that, about 450,000 children have taken the first dose. And about 180,000 has completed the 4 course of this vaccine, because it's a 4 dose in all to be given in children from 5 months to 36 months, and is given monthly. First dose, second dose monthly, third dose. After the third dose, you are losing about 18 months to give the 4th dose. And about 450,000 children have completed that course, and about 180,000 have taken at least the first dose. This can give a reasonable protection for about 2 to 3 years. And this is going to reduce the death rates of malaria prevalence within our region. And therefore, there is hope for looking at this. You already talk about the prevention strategies and so on and so forth. But clinically, if you're able to get a product that can reduce recurrence, that can minimize development of resistant strains to this condition, then I think we are on the right path. Thank you.
Thank you very much. You did very well. And I also need to add that our clinicians and our community health workers should be trained to make sure that we give the right drug at the right dose at the right time. And then
right.
At the higher level, we have to look at the issue of this resistance to make sure whether we are dealing with reinfection or reproducence, which is very important here. Then we find that we have to report early if we find any of the reproducence that is happening. So teaching and retraining our healthcare workers in this line will save the drugs. And then we avoid using empirical treatment as well, so that we safeguard the artemisinin combination therapy. Thank you very much. Dr. Chinda is back on course. Dr. Chinda, can you unmute yourself? Dr. Chinda? Dr. Chinda?
Yes, Dr. Grema, how are you?
Thank you very much. Can you talk on this global warming?
Okay, yeah. Apologies for the mishap in technology, but we are getting there.
Yes,
one step at a time.
I even said that in the management of malaria and towards strategy, we have to use appropriate technology.
Appropriate technology, Dr. Grema, yes. You got me on that one. So first of all, I just want to make it clear to the panel here and the rest of Africa that is listening. Unfortunately, I'm unable to put up my video because the internet is quite poor. So I'm here in my personal capacity as a specialist physician based at a public health institution on the Copperbelt province of Zambia. That's where I'm operating from. So as I give my views on this malaria elimination and new strategies, these are views that are coming from me, and I'm not here to represent the ministry responsible for health in our country, and neither am I here to represent the department that is taking the key role as when it comes to malaria elimination in Zambia. Yeah, so having said that, but most of the information that I'm going to give is going to actually come from what the country has done so far in terms of some strides to be made towards elimination of malaria. So before I can talk about global warming, I just want to take us back to the issue of the COVID-19 pandemic.
Yeah.
As you recall very well, COVID-19 came somewhere around 2019, late December, all the way through to 2020. So before we can even talk about global warming, everybody can appreciate the effect of the COVID-19 pandemic on diseases of public health interest, be it malaria, be it HIV, be it TB. It's like the focus of the interventions at that moment in time were all being weighed towards the fight against COVID-19. So we really have drawn back in terms of public health strategies that actually can help in controlling these public health diseases. So back to climate change. So the world is getting hot. I'm sure we can all agree that the world is getting hot. And this increase in temperature has especially been seen, more especially in the sub-Saharan Africa, which is identified as actually the most vulnerable region in terms of the effects of climate change. So if you look at the area between Somalia on the east up to all the way to Mauritania on the east, I think this is the area known as the Sahel region. That's where you have a lot of effect of the climate change. And we've also seen other issues of climate that are originating way down south. I think you must have heard about the storm that devastated most of the southern parts of Malawi, including some parts of south east Zambia and Mozambique. So all those things are coming, all coming up as a result of the climate change. Now, you have to understand is that the climate change it tends to have an effect on the on the diseases that are vector transmitted, such as malaria, where we know that the optimum temperature for the transmission of the plasmodium by the Anopheles mosquito is somewhere around 20 degrees Celsius. So with the increase in the global warming, you find that it's been reported that the malaria, or the parasites, or the mosquitoes seem to be migrating a bit upwards from the south, making transmission of malaria even to happen in areas where you found that it was found that malaria transmission was actually on the low rate. Coming back to the sub-Saharan Africa, especially in the Sahel region, you find that this place, apart from this global warming, we also have issues to do with war that is happening there as a result of insurgency and Islamist groups that are trying to have conflicts over territorial grounds. And this has caused a lot of migration. Okay, so people have moved from these areas and some are going to the neighboring African countries. But you can see in the news that every time we see our friends coming from here actually trying to cross the Mediterranean to go as far as Europe. So this has an impact on the malaria global picture as we look at it, because these people are actually traveling upwards and some of them are carrying these malaria parasites across, and they may actually be taking them to areas where you find that patients are actually, people there are actually immune to malaria, and this might further worsen the burden of malaria that we are trying to try and eliminate. So apart from that, the other thing that is happening as a result of climate change is that the areas where most of these people have actually been staying have now become a bit challenging for them to live there. So you find that there are floods, so they cannot cultivate, their crops cannot grow as they should, and this has made them have to leave these areas, and they try to also move a bit up in trying to search for certain areas where they can settle and try and grow some food, because most of the people in the sub-Saharan Africa, I think they get their food from subsistence farming. So all these impacts of the climate change, what are some of the things that seem to be driving the the malaria epidemic forward, and we expect to see the climate change having a very big impact. This is despite the fact that these greenhouse gases are actually not even generated in Africa per se. They are generated most in the European countries, but we cannot ignore the devastating effect of climate change and how it has changed the picture of transmission of vector-borne diseases such as malaria. Thank you.
Yeah, you do very well. Thank you very much for this input. That is very important issue now. All these strategies that is put in place, where all human beings live in different geographical area, with different social culture, and then our beliefs and practices are different. Dr. Teresa, how do you see these demographic, cultural practices affect these strategies that we all put in place, accepting ITN, accepting IRS, accepting prophylaxis, especially pregnant women coming to antenatal? Okay, how do you see our own behavior and culture affect all these strategies that are in place as it affects our strategy toward elimination of malaria?
Thank you so much. My analysis on this, our social and cultural practices still play a major role because we are Africans and most of us, we really value our cultures. When I look at it in, for example, the mothers attending antenatal clinic,
Yeah.
a lot of behavior change communication has taken place. And some of our mothers really understand what they really need to do when they get home. But some also, I may say they understand what they're supposed to do, but some are still tied to their cultural practices. So bringing them out of that still needs some time and a lot of behavior change and communication. So some of the cultural practices that I may point, for example, if a mother comes to the clinic and, for example, the net is given, if it is not accepted by the people at home, for example, even the husband, they may not use it. They'll have the net, take it home, but if it is not allowed, it will not be used. But I must appreciate in my setup, most women have really understood this, and we've also brought the men on board. We've done male involvement, and this has really created a good impact. Some people still do not really follow what they are taught. For example, we give the nets and they don't use it well. Some use it in their gardens, of which that is not recommended for their case. Some women also, they may take the SP and when they go home, they will still not use it. Reason being, they will tell you that the SP is not palatable. So they're not able to take it effectively. But again, in that case, we always encourage direct observation therapy, and we
Then
try
we
and
do direct observation therapy. Next that
yes,
they swallow in front of us.
yes, they swallow it at the clinic. But if they bring an excuse and go home with it, we end up losing on it. But that is
What of
what
our health seeking behavior, Teresa? What of our health seeking behavior? People that have first episode of malaria, do they come to the hospital promptly, or do they go to a more cheaper private health center, or go to traditional before coming to the hospital? Our health seeking behavior also matters here.
our health seeking behavior, yes, is also matters a lot. But again, in our setup, you find that the malaria treatment is always free. So when they come to the clinic, they're able to get it. But good health seeking behavior, I've only noticed it with the females. We still have a challenge with the males. They still want to go to the
Yeah,
clinic,
I
get
agree
their
with you.
medication from there, and by the time they come, maybe they already worsened. Or rather, it's now a severe form of disease. So yeah, you're right.
Yeah, that's very good. Dr. Emmanuel, you started talking about this malaria vaccine. I want to hear
Yes,
more of it because the World Health Organization say we're supposed to achieve efficiency of greater than 75% by 2030.
yes, yes.
And now we are just mentioning few countries that have started. What is the volume of this vaccine being distributed? And how is the funding? And how is the acceptance among community? for those that have started?
Well, in terms of funding, is from the Global Fund, Gavi, other stakeholder agencies. We in the endemic areas, it depends on the political will of government. We're not involved that much in terms of the funding, but we are ready to use. We are ready to use whenever it comes. But because there is these vaccination programs already laid down, in terms of administration of the vaccines for the 6 childhood killer diseases and an expanded program on immunization already in place, they're able to just add the malaria vaccines to it and give it. Yet still, behavioral and how do you call it? Traditional belief, religious beliefs also play a major role. Get some people at the hospital and they don't want to take the vaccines. So we need education in that direction. But I would say that the numbers that are withdrawing from the use of it are not that high. Further education is needed in that direction. The vaccine, can we say that it's coming late, or is if they started trying to develop this vaccine about 30, 35 years ago, we are having it now. It will be our job to promote it. So Ghana started by introducing it to about 42 districts. They add another 50, about 54 districts to it. Now it's rolled across the country and given at the vaccination centers to the mothers that seek antenatal care. So we will say it's a starting point because they just started in 2019. And as of December 2022, we have about 1,400 million doses, and this covering just about 450,000, and it's still low. We want to have more coming on board. And so we'll just say, although the goal is close by 2024, we are just initiating it and hoping that we can get a lot of people rolling onto it to decrease the death rates of malaria.
Yeah. Thank you very much. My country actually accepted that and approved it last week, about 10 days ago. So we'll see how it's going to be rolled up and then how it's going to be utilized. Dr. Chanda. Dr. Chanda, can you unmute yourself, please? Dr. Chanda?
Dr. Grima, I can hear you, Dr. Grima.
I still have issue on this clinical management of malaria because that's a fulcrum of management of a case. And that's a fulcrum where we can identify those asymptomatic by active surveillance. What do you think about this active treatment and prophylaxis? We know we have these vivax in some centers, but treating vivax, we have to do radical care. And radical care, you have to do with one particular drugs or group of drugs, ramiquine, which has a issue of a GCPD deficiency. If you don't screen them at what we call point of care testing, you're going to run into trouble. Give us more highlight on this clinical management, especially the use of ACT and then artemether lumefantrine. Because artemether lumefantrine, I can see that they have various formulations, including the use of infants and children, and then can be used in early pregnancy.
Okay, so let me start by just talking a bit about some of the strategies I think that have been in place, especially when it comes to malaria elimination. Especially, I think you talked rightly about there's the MDA protocol where they are doing the mass drug administration, and they are in some areas where they want to try the SMC, which is the one drive by seasonal malaria chemotherapy. So so these there are some countries that have adopted this. I think some of them have tried to add I think a combination of amodiaquine and I think sulfadoxine and primethamine in trying to achieve the mass drug administration. And then some countries are still a bit, they're still dragging a bit in terms of asymptomatic treatment in terms of malaria cases. And some have decided to try to opt for their own medication combination. I think I saw something that our malaria elimination center has done. I think they tried to use primaquine and in combination with I think sulfadoxine and primethamine in trying to do the seasonal malaria chemotherapy. Coming back to the artemisinin based combinations, I think it's well known over that the combination themselves they are quite effective in terms of malaria treatment. You have the artemether, the artemisinin component, which is quite very fast acting, and it brings down the parasite counts quite very quickly. And in those patients that actually have malaria, you find that they tend to get better quickly in terms of symptom relief. And I think in the past, there were issues that were raised in terms of adherence to malaria chemotherapy when these drugs were introduced, because most of the people would feel better way earlier in the course, and we are not actually managing to treat to finish up the dosages. But this has since been changed, and a lot of adherence and counseling has been important. The combination of the lumefantrine to the artemisinin even makes the combination even more superior, in that the lumefantrine is actually more long acting and stays for longer in the body, and it also helps clear off the parasites in the blood. And then the other advantage that these drugs have is that they've been tried and used in pregnant women, and we can also actually have them used in children that are under the age of 5, I think, which gives this combination of drugs a bit of superiority in terms of their coverage when it comes to the strides that we are trying to make towards the elimination of malaria.
Thank you. I think you are doing very well, and we are coming to close to the end of this session. But I have this statement, which I think Dr. Chanda will start. All of us will spend 2 minutes and then give our talk. From the historical view of malaria control, is an effort must be sustained by all stakeholders, especially for resource-constrained setting, not only for gains to be maintained, but to prevent resurgence of malaria. So it means we have to put head all together by all stakeholders, especially for our areas, low resource setting, to see that it's not only we maintain what we have achieved, but how to prevent resurgence. Chanda, can we start with you? Just 2 minutes remark on that.
Yeah, that's a very yes.
Global
Local
level.
Are you able to hear me, Dr. Grema?
Yes, go on.
Yeah. So I think we are trying. Let me say we are making progress. I can humbly say that, and I think that's the whole reason why we are having this meeting actually before the Malaria Day, because there are activities I think that are planned for tomorrow that we just have to make sure that are done. And I think most of the national malaria programs have tried to put everything in place in trying to fight malaria. I was looking at Gavi, and it was very exciting to note that approximately 30 African countries, they have expressed interest looking at the results that are coming out from the malaria vaccine that was being done in Malawi and the other 2 African countries. So the other African countries have also expressed interest, and they want to go on board. So this simply means that the African countries are committed to where concerns regarding the elimination of malaria are. So I think we are trying, I think, as a continent. And I think some countries are trying to increase their funding and also the sourcing for activities through the partnership organization that doing malaria program in Africa. For example, we have, I think, PATH. PATH is sponsoring some of the programs on the elimination of malaria in Africa. There are some other non-governmental organizations and faith-based organizations that have also come forward in trying to make sure that we try to achieve good scores in terms of malaria elimination.
Thank you. Dr. Teresa? Dr. Teresa?
Thank you so much. With all the interventions in place,
Yes.
I think we need to do a lot of campaigns from the community level. If there's good community engagement, we are able to help the people at the community level to know the real interventions and really take part in implementing the strategies that, I mean, in implementing the, what do we say, the activities that are geared towards eliminating, or rather reducing, the malaria burden. So at the community level, we have the community health volunteers. If they can cascade these messages up to the household level, we'll be making a milestone. Also, now that healthcare has become so expensive, we need to encourage the people at the community level to ensure that they are all in the insurance schemes, the health insurance schemes. So whenever we have any malaria cases, they're able to get to the hospital and get treated without feeling the burden. We also need to engage the political wing. We need to engage our members of parliament to promote medical bills that are geared towards increasing allocation in the budget, so that whenever there are malaria cases, we are able to swim smoothly without feeling the burden. Thank you.
Thank you very much, Dr. Emmanuel.
Yes. The bottom line is to also try to prevent the development of resistant strains. If I digress a bit, if somebody develops resistance to tuberculosis and it is passed on to another person, it is a resistant TB. And one school of thought says that such people who develop resistance must be put at the firing squad and shoot to death. Why? Because treatment is very expensive and many a times almost impossible. Looking at malaria and the possible development of resistant strain, and efforts have to be made and all resources put into looking at the molecules. As you said earlier, that some school of thought are looking at it, adding extra molecule to making it triple therapy, just to make it almost impossible for development of resistant strains. Because once it's passed on from one person, resistant strain, to another person, is resistant. And that can easily be spread by our environment that is breeding the female Anopheles mosquitoes that is spreading it. So in that respect, I'm excited about the product developers that continue to look at the molecules and the possibilities increasing their effectiveness. Already the drug that we have, as compared to maybe the quinine, have a better safety profile, have a simpler dosage regimen, 12-hourly medication, and within 3 days, you can complete the whole regimen. If we add another product, just as is done in HIV, you have all about 3 or 4 medications attacking from different angles of mechanism of action, then it's almost impossible to develop resistant strain. Then we can say that we are likely to achieve the elimination of malaria in the near future. Thank you.
Yeah, very well, very well, very well. Thank you. If we want to safeguard what we already achieved and to improve on it, so that we don't cause relapse in it, all what you said is what is going to be done for us to sustain it. We have to put active surveillance in place to check all the strategies that we put in place in order to identify the lapses in all aspects, be it ITN, be it IRS, be it all sort of vector control, be it all drugs that we do, and be it all the behaviors that even the vectors are involved in and changing behavior. And then the human behaviors now, we have to put an active and passive surveillance for us to look at the leapfrogs and then get yearly appropriate report to the authorities. And then we engage global and regional and local level to support all the action. This is a very rich engagement. My panel have done a good discussion to the topic. May I go back to Raul if we have some questions so that we can take them?
Thank you so much, sir. And so thanks for this very stimulating and insightful discussion. I would say that very thoughtful interactions I have heard, which is not just for, it is not just thought provoking for healthcare professionals or community workers, but also for drug makers. Like I'm referring to Dr. Emmanuel's last comments, right? How even drug makers can think innovatively about bringing newer combinations, newer medicines in this fight against malaria. And thank you so much, all the panel members, for addressing some of the most complex and pressing challenges in the management of malaria, for sharing very innovative strategies and very much real life examples from your rich experience. So, with this, please allow me to take some questions coming all the way from the audience on their behalf, right? And I request the panel members to respond to these questions. Most of the questions are already covered in this interaction in while this panel discussion was happening, and I have filtered off such questions and going to a few questions they are not yet discussed. So, starting with the malaria control, one of the attendee would like to know that which are the different species of fish they feed on mosquito or larvae. They can be used in the control of malaria spread.
Yeah. Dr. Chanda, control of mosquito larvae, different mosquito larvae.
Hello, can you just go over the question again?
Okay. Now, can you go over the questions again?
Yeah. So, Dr. Chanda, which are the different type of fishes they can be used in the to control the spread of malaria, particularly fishes, feeding on uh, mosquito larvae.
Okay. I know that we have our mosquitoes. They breed in areas, especially where there's stagnation of water. But you can also get to have other massive water bodies where you can have mosquitoes breeding from. And I think in concerns of elimination using fish, I may need to refer to Dr. Bogagrema and see if there's any. But what I know is that most of these areas where this transmission is occurring, especially if it's seasonal, you find that there are these small areas or small areas where there's accumulation of a lot of water in the seasons, and I think it's not possible for you to do any aquaculture in there. And if there is anything, I would ask Dr. Grema to come in and see if there's anything that can be done in that area. But truth be told, it can be quite challenging when you try to eliminate using that method that the viewer is trying to find out. Dr. Grema, sir.
Yeah, it's a very important question. It's a very valid question, especially for rural setting. For control of larvae, the issue of using organophosphate like DDT is the one that can clear everything. But there is caution in using those chemicals because it will destroy the environment, the normal flora, the normal plantation that we have. And then the use of the indoor residual spray also could be used outside. But the issue is how much of it could be used inside. So it's not cost effective. So the most cost effective in the control of larvae is the environmental sanitation. Yeah, clearing of our bushes, clearing of water and storage. And the new vector now that can survive in our individual water safe, that is the Anopheles stabensis, can survive and the larvae can grow inside where we wash our plates. So the issue of that also needs to do with important use of safety chemical. Carbonate can be used but cannot be used as an environmental chemical. It has to be used as an insecticide treated bed net. So by and large, issue of larva control is the use of cleanness of the environment, clearing bushes, clearing water stagnation. And I think, and then the use of chemicals outside is not actually cost effective in our resource constraint, but is to educate our population on the use of environmental sanitation. That is the key word. Thank you.
Let me add on to that. Can I go ahead?
Yes, ma'am.
Yeah, thank you. Currently, there's use of biolarvicides in the level source management. Yeah, and the biolarvicides are safe. So that one again can also be used. Thank you.
Great. Thank you so much. Let me move on to the next question. And there are many questions actually from this area, that which is the most safest anti-malarial drug used in pregnancy, starting from first trimester and throughout pregnancy.
The safest anti-malarial to be used in pregnancy is the oral quinine. And it's usually dosed 10 milligram per kilogram body weight, 8 hourly for 7 days. And you can see the duration takes 7 days. The ACTs are normally recommended to be used from the second to third trimester of pregnancy. But within the first trimester, you can use your oral quinine. But the moment you move to the second trimester to third trimester, you are looking for one that have a better safety profile, a better frequency of administration. Because if you take the quinine, you are looking at 8 hourly regimen, which is 3 times a day for 7 days. But when you move to the ACTs and you are using artemether lumefantrine, for instance, you are using the first dose, and then 8 hours later, you are using the second dose, which means within the first day, you are using 2 doses. And these tend to clear the parasite faster with fast resolution of clinical symptoms. And for the next 2 days, you are done with the medication. Comparing the side effect profile of this artemether lumefantrine, resembling basically the symptoms of the disease condition like headache, dizziness, weakness, as compared to the quinine, which can have, if there is a higher dose, then you're having hypoglycemia, and the patient have to be screened for G6PD deficiency, as Dr. Grima has said earlier on. How many facilities have these screening methods to use? And then if you do try and error, the end result can be that bad. Safest throughout pregnancy, yes, is quinine. But beyond the first trimester, you are good to be looking at the ACTs because they have a better safety profile, better frequency of administration 2 times a day, and then shorter duration of treatment, 3 days, and you are able to put the person at ease by clearing the malaria parasite.
Perfect. Okay. Yeah. So, can I move on, sir, or
go on?
Okay. Fine. So, next question is very specific to Dr. Teresa. I think our Kenyan audience would like to know that what specific cultural reason will restrict mothers from using insecticide treated nets when pregnant?
Thank you so much. Cultural reasons, they vary from people and what people actually believe in their own context. A very specific one I may not tell, but when they come to the clinic, they'll come with stories and they'll tell you, this is what we believe in, or this is what my husband has said we should not do. Okay, but there's no very specific one. Thank you.
Yeah, can I add something to that? Since the
Sure,
net
sir.
is usually treated with a chemical, permethrin, maybe for example, some people who may have hypersensitivity reaction to the chemical may be uncomfortable to use it. In one of our communities, when this was spread around for them to use, the community was refusing to use it because they claim once they sleep in the net, it's like they are sleeping in an enclosure. They cannot breathe. It's a net, a lot of air is around, but they said once they sleep in the net, they cannot breathe. It takes us a tough time to be able to penetrate that community by education, by demonstration, by piloting to help them use the net. And the question, sometimes I wonder, we breed the mosquito, they are all around, and we say that, oh, when we want to prevent sleep in the net, are you going to be there the whole 24 hours? Won't you be coming out? It says since hunters have learned to shoot without missing their mark, the bird also has learned to fly without perching. So the mosquitoes are also waiting for you to come out of the net, and then they will do justice to you. So the environmental sanitation should be on our agenda, because that is where it starts from. Most of the developed communities that are able to eliminate these malaria, sanitation and the use of technology is quite high at their end. And I see Dr. Grima continuously say that cleaning of our environment, eradicating of the stagnant waters, because that's where we breed them. If we are able to do that and across regions so that we prevent importation of malaria from one region to the other, then we can be achieving a better result in that regard.
May I just come in a bit on the same topic of the mosquito nets, the ITNs? I don't know if you have a lot of fishing regions in the areas where the other panelists are coming from, but I just want you to know that in some areas of the country, there is very high acceptability of the mosquito net, not because they are going to be used for the sole purpose that they intend to, but you find that the fishermen actually are getting these nets from the people that have the nets, and they have been used in some areas actually. They have been used for fishing instead of being used for the sole purpose that they are intended. So the counseling has to be ongoing. We don't need to stop. So we just have to make sure that we give people the information and counsel them on the importance of the nets.
That's true.
Right. Thank you. Moving on to next question, which is specific to Dr. Emmanuel. Sir, what is the role of pharmacist or chemist, in the testing of malaria? Or rather, can malaria testing be done at pharmacy levels?
Yes, thank you. Fortunately for us, as I said earlier on, that the malaria condition, especially the uncomplicated malaria, is classified and can be managed at the primary facilities like retail pharmacy outlets, so that anybody can walk into the pharmacy, complain of his or her symptoms, and after interaction with the pharmacist, the use of the RDT, the rapid diagnostic testing, to confirm presence of malaria. And then at that facility, it is recommended that we can give the ACTs at the primary level, at the pharmacy level. And the daily attendance to the pharmacy, the case that are involved are about 50% malaria, uncomplicated malaria. So that if we identify the symptoms and we realize that it's uncomplicated malaria, we are allowed to treat it at the pharmacy level. If for any reason the fever is above 38.8 degrees Celsius, or there is signs of severe malaria, then we do referral to the hospital. So in our community, we can treat malaria at the primary level, at the pharmacy level. And the pharmacists can make recommendation as to the type of drugs to use, and then the supportive treatment in terms of analgesia and other things. Thank you.
Thank you, sir. So I will just move on now to next question is which is wide open to all panel members. And since Dr. Emmanuel, you have mentioned briefly about uncomplicated malaria. So talking about now complicated or severe malaria, which is the first line of treatment for severe malaria as per you panel members?
Well, talk. Okay, let me listen.
Okay. Well, since the introduction of the new malaria program, we have moved away from using IV quinine for severe malaria to the use of IV artesunate. And that the IV artesunate is given according to the loading dose of 2.4 or 3.0 milligram per kilogram body weight at 0 hours, 12 hours, 24 hours. And then you convert to oral to ACT combination to complete a 3-day course. So currently is IV artesunate. That is the recommended medication. Again, is because of the faster resolution of the clinical symptoms as compared to IV quinine. When you are using IV artesunate, you don't need to do any pre-medication as you would do with IV quinine. Because if you use IV quinine, there's development of hypoglycemia. There's increased sensitivity of the insulin cells to this glucose. So there is development of hypoglycemia. So you have to give a higher percentage of dextrose so that the person do not move into hypoglycemia and hypoglycemic coma. But if you are going to use IV artesunate, you don't have to do pre-medication because it doesn't have that as a side effect, and therefore having a better a profile. And then the duration of treatment also is shorter with IV artesunate as an is oral ACTs than the IV quinine. Thank you.
Yeah, you are quite right. It's quite in order. But if you look at low resource setting, where the IV artesunate needs some calculation and needs some diluents, like carbonate to put, and there is easiest artemether injection, which could be easily be given by IM.
Right.
Then it reduces this hypoglycemic effect and is going to be easily given by community health worker, and there with the prompt referral to appropriate center as well. And there is also this formulation that you can give rectal, and once you give rectal, and then you now control temperature by TB sponging, and maybe if you can swallow paracetamol. If not, you just put the rectal preparation and then refer promptly to the next level of healthcare. You are quite in order.
That's right. Thank you.
Just look at the more remotest area that you don't need to,
That's
you
right.
cannot get
That's
the
right.
IV line, and then the calculation of the artesunate, and then the issue of diluent also, and the calculation of putting these grams or whatever per kg and whatever, it will going to be maybe too cumbersome for a common community health worker. Like this is where every healthcare worker, be it a pharmacy, be it community health extension worker, can now take care of this, identify the emergency at first, give the first dose, and then move the severe case to the next care level.
And that is very true, because sometimes even trying to locate a vein of the child is a problem. So in such areas, the IM artemeter could be recommended. Thank you very much, Dr. Grima.
Okay. Let me just come in a bit on that one. I just want to agree with Dr. Grima and Dr. Emmanuel over what the first line drug that we are using. I think for treatment of severe malaria, I think we are using artesunate. I think even in Zambia, that's the first line drug that we are using. And I think some of the advantages Dr. Emmanuel already highlighted them concerning the other problems that it has in terms of causing hypoglycemia, and also the frequency of dosing, which is 12 hourly, which makes it very easy to use, and also the fact that you can give it IM. And also due to the fact that in resource limited areas, sometimes it becomes very difficult for you to have access to other tests, supportive tests for patients that have malaria, especially for the kidney function tests. And you find that one of the complications of severe malaria is actually black water fever, which causes acute kidney injury, in which cases it becomes difficult for you to use quinine, but you can still go ahead and be able to use artesunate. So I actually agree with the panelists that have gone before to say artesunate has actually helped change a lot of things in the management of complicated cases of malaria.
Great.
Raul,
Right.
any question?
Yeah. So I will go to last question now. There are many questions, right? But I can understand, right? We have time limitations. So in the interest of time, I would like to take up the last one, which is not a question as such, but it looks like a comment, but I feel that it is worth taking up here in this discussion, that there are real challenges in terms of training health workers at the rural areas to handle issues relating malaria very well. So, what is your thoughts, panel members, on this particular challenge?
Teresa, training of community health workers to handle malaria.
Yeah,
Let's
thank
take,
you so
let's
much.
say, for example, this question goes down to the lower level. Let's take we have a malaria post.
Okay, thank you so much. In our setup, we have been able to train the community health workers, even the facility health care workers, through the partner support. We have partners through Global Fund that are able to support. So the CHVs, that is the community health volunteers, they are trained on community case management, and they are able to diagnose malaria at their level. But now it's limited. They cannot treat complicated malaria. They're only able to, for example, when they get to the community, they're able to take the temperatures. If it is 37.5 degrees and above, that is an entry point. So they go ahead and use MRDT to test for malaria. And in case there is a malaria negative slide, they will refer the patients to the next level of care. That is the facility in which they are linked to. If it is a positive slide, they are able to treat for malaria. And if there's a sign of severe disease, for example, a mother brings a baby with convulsions, they are not allowed to treat. These are patients that they refer immediately to the link facilities. Even the expectant mothers, they are not allowed to treat. They will only take the temperatures and refer them to the facilities in which they are linked. So again, not only malaria, they're also able to do other not investigations per se, like for example, taking work mid upper arm circumference for the babies, maybe to diagnose malnutrition. And yes, they're also able to refer if the children are having fast breathing. That is, they're able to handle the clients in the community holistically, not only malaria. And when the patients get to the link facility, they'll be managed accordingly, because in our setup, even in the lowest health care level, that is the dispensaries, they're able to treat malaria cases. And in isolated cases, they're never able to treat. They actually refer to the next level of care. That is how we've been able to do it. And the training for the healthcare workers, I must say, it is very comprehensive, and it has been done so well. And most of our healthcare workers are able to treat accordingly. Yes, and a few with challenges also, really, they're able to consult and give the right management. Thank you.
Thank you so much, ma'am. So before I conclude, I would like to know if any other panel member would like to add on this particular point?
Yeah.
Yes. Okay.
Okay, Chanda,
Mr.
go.
Emmanuel, you can go first. Okay, thank you. I just want to quote something from I think Dr. Grema, and I think it's very important. And I think he had earlier asked me and talked about sustaining uh, all these efforts of malaria by all stakeholders, okay, especially for the resource limited countries, okay, or resource limited settings. So what you have to agree with me is that most of the resources that are available for the trainings can only have a certain group of healthcare personnel to get oriented at a time. Okay, and I think this has come in part due to the fact that most of these trainings and programs that are being conducted are usually linked to some form of remuneration at the end of the day by the participants. So I think moving forward, the other thing that we could try to employ, or the other thing we could try to exploit, is making sure that we do enough sensitization to the healthcare personnel and be able to motivate them and tell them the ultimate goal of what we want to achieve as we do these trainings, so that we try and have more people to come on board without expecting much of remuneration to come, but looking forward to making sure that they're able to do the right thing in the areas where they're practicing from, as we try to drive the agenda forward in trying to eliminate malaria. That's what I would want to add.
Yes, thank you. I think training is the key. Like I said, surveillance is the key. Training it has to be in stages. You trained from the basic volunteers in the community. What you give them is different from those that have what we said health qualification. Those volunteers have their own role, and those with basic qualification in healthcare management have their own role. That the training should be continuous. Those with the healthcare qualification, you have to train them based on a module or based on a logarithm, and then based on what we call integrated management of diseases, where they can easily identify this is this and this is not this, where they can make a diagnosis with a simple machine that is available, where they can administer a medication as easily as possible, where they can identify those that could be referred. And then the training goes on up to the top level, where you identify a rich pharmacist, you identify a nurse and midwife, where you identify a medical officer. His own training level is different. And then when you come to receiving comprehensive centers or a tertiary institution where they deal with complicated cases, their training is different. But all the same, the each level of cadre in most countries, you have primary healthcare development agencies or primary healthcare agency. Then we have secondary care that's owned by state and then owned by federal, and then the training at different level of cadre is, but it has to be continuous for us to achieve what we wanted.
Not to bore you, I will say that Madam Teresia, Dr. Chanda, Dr. Grima have basically taken the words out of my mouth. They spoken my mind. All that I can do is to throw my weight behind them, and I have a good weight just to throw behind their conclusions. Thank you very much.
Thank you.
Thank you so much. Thank you so much to all panel members, especially to Dr. Grema for this for wonderfully moderating this session, and to all panel members. I have personally enjoyed this session a lot. It was quite an interactive session. Thank you, Dr. Chanda. I'm sorry you missed your introductory part, but you managed to join at the right time this discussion. Thanks for making it. And I'm sure our audience will walk away with a critical understanding of the topic today. And I would like to thanks to our awesome audience across sub-Saharan Africa for showing constantly growing interest in our monthly webinar series. Thank you so much to our partner professional bodies and societies for CME and CPD accreditation. Thank you so much. This is Dr. Rahul Mandlik signing off.